So our next speaker is Terry Altilio. I first heard Terry speak back in the early 90s at a conference at Memorial Sloan Kettering in New York City. And I've been very fortunate because I've heard her speak many times since then, as I'm sure many of you have as well. Terry is a palliative social worker with 34 years direct practice experience, most recently in the Division of Palliative Care at Mount Sinai, Beth, Israel in New York City. She is recipient of the Mayday Pain and Society Fellowship Award of 2006 and a Social Work Leadership Award from the Open Society Institute's Project on Death in America, which supported the first Palliative Social Work Fellowship and a listserv currently networking over 800 social workers. In 2013, Terry received the Project on Death in America Career Achievement Award. She lectures nationally and internationally and in master's and postmaster's programs at NYU, Smith, Fordham, and California State University on topics such as pain management, ethics, language, and psychosocial issues. She has co-authored publications and is co-editor of the Oxford Textbook of Palliative Social Work, Palliative Care, a Guide for Health Social Workers, and also the second edition of the Oxford Text of Palliative Social Work to be published in January of 2022. It's my sincere pleasure to introduce Terry Altilio.
All right, everyone. Thank you for that kind introduction, and you can tell by how long you've had to wait for me to speak that one of my greater skills is not technology. And I so appreciate following Dr. Smith and will try my best to give you in a very quick fashion a perspective on the ethics, the public policy issues that come together around this most important topic. And my fond hope is that by the time you leave this conversation or this, yes, it will be some semblance of a conversation, you will find a place to have a passion for this topic. So we're going to start with Ruby and we're going to end with Ruby. Ruby is an African-American single mom of a 10-year-old son. She has pain from metastatic cancer, managed at home with patient-controlled analgesia. She comes to an outpatient visit, brings her home health aide with her, and she's talking with 3 white clinicians. It was not one of our better clinical days. We were in a very small room. There were only 2 chairs. Ruby and her home health aide were sitting. We were standing, 3 white clinicians, all female, all dressed in white coats. She has escalating pain. She doesn't want to increase her medication, which is morphine. She says, my friend works in the hospital, and she says this is the medicine the doctors are using to kill the patients. We will talk about Ruby at the very end. So the silence is no longer an option. Hence, that is why I named my talk, Time is Up. Time is up. Silence is no longer an option. We have known about the inequity in pain care for decades. So the care of patients who suffer, whether with or without pain, is a shared responsibility, and yet the risk for each discipline is not equal. And we know that it's not equal because it will never be me who has to bear the responsibility for somebody who misuses their medication, who sells their medication. That will not be my responsibility because my name will not be on those prescriptions. So it is important for those of you who are social workers, psychologists, nurses, for us to have compassion for those who are prescribers. Persons in pain are treated within converging contexts, within relationships and environments which are impacted by individual, team, institutional and societal values, history, beliefs, and influences which invite, at the very least, inquiry, curiosity, attention, and action, yet the risk is not equitable. This is a sort of a graphic about where patients, families, and clinicians find themselves when it comes to pain. No other symptom is featured in this way. No other symptom is seen this way. And that is because of the medications that we use to manage pain, but it is also broader than that. There is somebody that I will quote in a little while. His name is Keith Walu. He wrote a book called Pain, A Political History. If you get really into this topic, it is very interesting to read about the place of pain in how we see human beings and how we see human experience and how it gets politicized. So patient and family and clinicians are in the midst of insurers. We know that we have to get prior approval for certain medications. Legislators, Dr. Smith talked about that. Regulators, the DEA, they want to know what we're doing with controlled substances. The media, who have their own responsibility, and in terms of how they present issues related to pain. Litigators, it's absolutely fascinating to read the litigation that has evolved around pain. People have been sued for the undermanagement of pain, if you will. They have been sued for the overmanagement of pain. Some folks have been sued under elder abuse statutes when older persons in the community, in their family, were not treated appropriately for pain, and suffering was extensive, more than one would have anticipated given their illness. And both of those lawsuits were successfully litigated against the providers. So litigation is a topic that infuses pain. Generally, it doesn't infuse other symptoms. Advocacy organizations and the organizations that have come together today are advocacy organizations. Industry, they are particularly interested in pain, and for many, many decades, they were the only people that gave any money to support studies about pain. So a sampling of mandates, ethical mandates related to pain, ethical principles. We know these ethical principles: justice, beneficence, to do good, to do no harm. Do these principles both permit and require that we care for people who are experiencing pain? Fidelity, competence, and non-abandonment. Non-abandonment is a really interesting one. Non-abandonment relates to doctors who are now saying, I'm not prescribing any opioids. I'm going to put them in a parking lot and abandon the value of a whole class of drugs, a whole class of medications in the treatment of pain. Fidelity is about truthfulness. It's about being honest and being credible in our care of patients. So the standards and guidelines are important to think about, because they are guidelines against which many prescribers will be held. So if one prescribes in a way that is not according to a standard and guideline, it is very important to document why you are doing that and what the process is about of your thoughtfulness. So standards and guidelines are usual and customary, yet they're applied to unique circumstances. And there is a fiduciary moral responsibility for technical competence, and that is for all of us. Patients and families often come to us trusting that we are doing our best and keeping pace with science. We'll talk in a minute about those who come to us believing that our systems are untrustworthy and that perhaps we are not trustworthy either. And Dr. Smith talked a bit about why folks might feel that way. So there are social and political circumstances that profoundly influence the health and well-being of people. Early not to social determinants of health, which we know have influenced pain management for decades and decades before people were even talking about social determinants of health. Why is pain unique, and why does it lead to undertreatment? It is unique because it is universal. It is subjective. It's a subjective experience that is a subjective experience experienced in settings that privilege objective knowledge. It's culturally, spiritually, emotionally, and socially infused. It is what makes pain an amazingly rich topic for clinicians to immerse themselves in, to assist patients and families to understand how these factors all come together in their subjective experience of their bodies and their illnesses. So who are undertreated? Those who are older, cognitive impairment, younger, female. We know there's an amazing data on gender and pain management. English as a second language. Low literacy and numeracy. And numeracy is very important. We don't talk enough about that. That really relates to the fact that people do not think in numbers. They walk into systems that are data-based, and we expect them to accommodate to us, to our dependence on numbers. Many people do not think in numbers, and we need to be conscious of that. That's why we have different kinds of pain scales, and that's why we are really adamant and intentional on how we ask people to tell us about their experience. Persons of color, unintended consequences. The unintended consequences of the lower and inappropriate prescribing, undertreatment of patients who are persons of color, African American, Latinos. is that there is a lower percentage of increase in deaths. The other thing that has happened, and I'll talk about that now, is that since pain and the deaths related to opioids have moved into the white middle class community, it has become a public health issue. So we have moved from a criminal issue to a public health issue just by virtue of the fact that so many white middle class folks are dying of opioid abuse. So do no harm. Harm occurs when the amount of hurt or suffering is greater than necessary to achieve the intended benefits. Here lies the basic ethical challenge to caregivers. Pain seems harmful to patients, and caregivers are categorically committed to prevent harm. Not using the available means of relieving pain must be justified. Look at how old that quote is. We've been talking about this for decades. Here is another one, Journal of Law and Medical Ethics. Human dignity requires and demands that unnecessary treatable pain be relieved. Severe or chronic pain blocks or seriously impedes the realization of almost all other values. Relief of unrelenting pain is required to allow the human being to think, to reflect, enjoy human relationships, and here it is, and to think and function on a most basic level. Justice. So the principle of justice is violated when people do not receive care equal to others. It is violated when subgroups of patients receive less adequate pain management and disparities continue. And do we not, all of you who are listening, have an ethical duty to challenge conditions that create hostile environments, including interventions suggestive of law enforcement or risk aversion rather than patient care? This is Ben Rich, the year 2000. That's over 2 decades ago. Opioids are indispensable in the managing of pain. This is about the ethical principle of balance. It's a good principle to keep in mind when we talk about managing pain and protecting public health. Opioids may be indispensable to managing pain and may also be abused. Happenings in the world do not obviate our ethical duties to patients. Continued suffering must be the result of inherent limits of science rather than lack of knowledge. Our efforts to address abuse should not interfere with legitimate medical practice, and pain and symptom management we know is ethically defensible in end of life, even if treatment might impact life expectancy, might. And the use of palliative sedation, this is interesting to me. The use of palliative sedation may be engaged more often as a consequence of a lack of knowledge. So the less physicians, nurses know about the competent management of pain, the more they may be inclined to sedate patients, which is really an interesting thing because palliative sedation takes one's consciousness at end of life. And for many people, consciousness at end of life is valued. So the data in the US in 2019, 70,000 drug overdose deaths, opioid overdose deaths was 49,000. You see white non-Hispanic 35,000, Black non-Hispanic 7,000, Hispanic 5,000. Male, of course, increased higher than female. And I talked about this as deaths have increased in the white community, impact on stigma has changed. I read an article in one of my local papers which said that obituaries ought to include the substance use disorder and overdose on medications as a cause of death, which is interesting to think about in relationship to stigma. Public health crisis rather than a criminal response. There is precipitous deprescribing, and I'll talk about a study in a minute that relates to that, and there is an emphasis on treatment resources and education. Johns Hopkins has a 4-day education on pain, and there's a call for education curricula for healthcare professionals, of which this is a part. Organizations have disappeared, which I think is really amazing. The Joint Commission no longer talks about pain as a 5th vital sign. American Pain Society has disappeared. Deprescribing amongst a veterans population. This is 2018. Among patients testing positive for illicit drug use while receiving long-term opioid therapy, the clinicians are substantially more likely to discontinue opioids when the patient is Black. That's 2018 study. The answer does not rest in abandoning the use of class of medicine. nor does it rest in treating those already at risk of undertreatment through the lens of white distress. I find that so interesting. Keith Walu, you have about 4 slides of references at the end of this talk, and 1 slide is all about videos. And they're amazing videos, and they're wonderful opportunities for shared learning. I think sharing a video with colleagues is really a wonderful way to learn together. Keith Walu talks about that we cannot that we cannot undertreat because we're looking at things through the lens of white distress. And he talks about fairness, which is such a simple word and reminds me of my childhood when children will say, this is not fair. And what we are seeing in the treatment of pain is not fair. Okay, we have to learn how to assess and treat, advocate, and build. This is a wonderful, just a compilation of people that I've been listening to lately who I find very powerful, and I hope you will read some of their stuff. Jason Callahan is a chaplain, works in one of the Virginias, West Virginia, and he did a talk for ECHO, and he talked about, this slide is about building trust and trustworthiness. Because when people come to us for pain management, they need to feel that they can trust not only our knowledge, but that we are not going to harm them. We are not going to harm them through our medicine. So the question is, how do we build trustworthiness within our institutions and without our professions? And one of the points he made is that you need to consider the history of your institution and the history of your practice. What is the history related to racism and inequity in the institutions? The history that I remember seeing when I worked at Memorial Sloan Kettering, when I worked at Beth Israel, I suspect it is the same at Mount Sinai. When you look around the walls, you see a lot of old white men. That is the way the history is reflected. What he was trying to say is you need to dig deeper than that, and you need to understand the history of your institution with the community it is hoping to serve. Part of that is how you build trustworthiness, is to know what went before. And then there is a person named Terry Laws, who's a professor at the University of Michigan, African American Studies. And she talked about what do we need to do to become trustworthy? And she talks about reframing mistrust as situational mistrust, which I think is very helpful, that it is in relation to a situation. It is not a characteristic of many human beings. It is rather a characteristic, a way of being in relationship to institutions that they have not been able to count on. She talks about barriers as being protective. And we're going to talk a little bit in a minute about the barriers to pain management. There's a lot of literature on barriers to pain management. And I think if we think about those barriers as possibly protective, we deal with them in a different kind of way. We deal with them not as something we overcome, but as something that we need to understand and discover. Why is it this way? And Keith Walu says we need to move away from pain management by substituted judgment of the clinicians to an intersubjective understanding and a respect for situatedness of persons. And as Dr. Smith says, how do you do that in 15 minutes? One of the ways you do it is to share it with your interprofessional colleagues. And it becomes a shared work and shared responsibility. Once again, not without risk being the same. I want to talk about delegitimation. And delegitimation is the withdrawal of legitimacy, usually from an institution, but we're not talking about an institution. We're talking about diminishing or destroying the legitimacy or the authority of patients in how we talk to them. Delegitimation, this is a study of the impact of disbelief in chronic pain. Newton explored the social context in which individuals experience disbelief or feel discredited. And the key results integrate to form three themes. One theme is stigma through actual or perceived encounters, when we psychologically explain people's pain rather than understanding that it is a combination of many, many factors, and often in cancer patients, a sign that something is going on with their disease. And yes, they might have a reaction to that. that is psychological, emotional, or spiritual. It's a perceived challenge to the integrity, and therefore it affects the identity of a whole person. And it may be influenced by negative stereotypes of women. The result is isolation, either self-isolation or isolation that comes from the fact that people have worked so hard to be believed and have not been believed, that we're looking at depression. Disbelief can lead to emotional distress, guilt, or depression. In pain, what does delegitimation look like in the language that we use? This is what it looks like when we hear people talk and when we read things. Likes the Percocet, claims to be in pain, doesn't look like they're in pain. They're asking for oxy. We should talk about OxyContin, not oxy. Oxy is the street word. They're dying anyway. Who cares if they're addicted? We do, because we know that when we use pain medicine appropriately at the end of life, we're not talking about addiction. Non-compliant, non-adherent, very, very scary words when they're used to label patients, because they influence care in a profound way. All this is going to be much more paid attention to in the setting of open notes. Dysfunctional, drug-seeking, clock watcher. These kinds of behaviors, I had a nurse that I shared space with for a long time, Candace Coggins, and she would talk about behaviors that look like drug seeking can actually be relief seeking. And that the work in this is to understand it as data. Addict, junkie, clean and dirty. This is an amazing population that we talk about as junk and dirty. We need to clean up. We need to think about the language that we use related to substance use disorder. Narcotics is a law enforcement word. I think it's better to talk about the class of medicines we're using rather than talk about narcotics. Diverting, if one prescribes for somebody who they believe is diverting, that is actually a felony. So we need to pay attention to that. And how do we pay attention to it? I'll tell you in a couple of slides. This is some recent work. You see 2021. Why are people doing this kind of work to pay attention to language? Because of open notes. This is a new phrase I just learned about, testimonial injustice. I love it. That which occurs when a speaker receives unfair deficit of credibility due to the prejudice on the part of the hearer. And that's what Dr. Smith was talking about when she's talking about bias in us. Bias in us, testimonial injustice. Consequential harms of not being believed and of discrediting people's reports of their experience is acted out all the time in law enforcement's response in Black communities. Their experiences are diminished, discredited. There is an amazing part on one of the videos on the slides is a John Oliver tape on bias in medicine. There is an amazing clip about an African-American husband who did not assert himself around the care of his wife who died, his pregnant wife who died, and his feelings about why he did not assert himself in the medical community, did not want to be seen as an angry Black man. So the videos are really profound. I hope you will use some of them for your teaching and for your sharing and for your building sensitivity to where you are in all these topics. So in healthcare, if we use these kinds of labels and so on and so forth, it delays diagnosis, inappropriate treatment, unnecessary pain, and possibly people die sooner than they need to if we discredit their experience and don't respond in the way that we might respond to another. They link these testimonial injustices to substantive harms, similar to the harms of microaggressions and the experience of those who are disbelieved. I think this is beautiful. When discredited, we are dishonored as human. It's a symbolic, consequent, core epistemic insult. Epistemic insult. So what do we do when we hear these words? Because we are supposed to now be acting, not complicit, but acting. So it's data to be explored. Tell me what you're seeing that you think this patient is diverting medication. Tell me what you're seeing that you think they have an unhealthy relationship to Percocet. Because that by doing that, you are asking people to be responsible for their judgment and responsible for their labels. We redefine, reinforce, and reframe. So the idea that behaviors might be considered relief-seeking rather than drug-seeking is a reframing. We use words and phrases we would like to hear people use, but sometimes we have to be more direct than that. We ask questions. It's a process of discovery. to get underneath what is it that our colleagues are seeing that warrant them throwing into the ether, if you will, words and descriptors or patients that can do harm. We explore issues of trust. There used to be a show with a bumbling detective whose name was Columbo, and he always acted confused, but he was not. And sometimes we are. So I'm confused, nurse. I'm confused, doc. What is it that you're seeing? And if you're seeing that, why do we continue to write the script without doing an assessment for substance use disorder? That doesn't feel right to me. I need your help. I need your help to understand how we can help this person in pain, rather than the answer being abandonment or abandonment of a whole class of drugs. And we affirm a shared mandate to assess and provide best care. So I talked about barriers. These are, oops, I went backwards. That's not good for me since I wasted everybody's time with my technological bumbling. We talked about barriers. There are clinician and systems barriers. Dr. Smith talked about some of those. Some physicians, certainly, some nurses are afraid of hastening death. They're afraid of regulatory scrutiny. There's an absence of trust, absence of time. We talked about that. Absence of knowledge. There ought to be no reason to have an absence of knowledge. This is 2021. There's knowledge all over the internet. Might not be the best knowledge, but you've got up to date. You've got all kinds of resources out there. There is no longer a reason for docs to say, I didn't learn about pain in medical school. That's sort of lame in 2021. There are emotional factors, which is what makes the study and the work of pain management so rich when it is engaged at the level that it can be engaged. Because we know that patients and families may not want to acknowledge pain because it means their disease is progressing. They may not want to acknowledge it because they believe that it will cause pain to cause suffering to their family, or their family may want to see them suffer, and therefore not want us to manage their pain. It's one of the most complicated and rich aspects of our care when we actually look at it through the rich framework that it can be looked at. The beliefs and values, you can take a look at these because I believe we're going to share the slides with you. And we know that spirituality infuses this topic. Pain is inevitable. It represents sacrifice. Sometimes it represents redemption for people. That's very important to negotiate around. We don't ever want to disrespect people's values, but sometimes we can actually negotiate around them in a setting of respect and trust. So fears, distracting or bothering, we know that patients come to us, they don't want to bother us, they're afraid if they talk about their pain, we're not going to heal their cancer, which is what's so wonderful about having palliative care in the oncology settings, because there's a little bit of a different focus and they can get both things, we hope, if people are working together. And we know that people now are more and more worried about addiction. And folks also deny pain or don't want to talk about pain because of its symbolic significance, what it means in terms of the disease. These are some of the things that Dr. Smith was referring to as well. The systems issues, historical and current racial and gender biases, insufficient resources. Dr. Smith talked about that, and we talked about absence of trust. And these are aspects of patient experience, which may infuse relationships and decisions. Attributed meaning is the internal dialogue. What does somebody say about their pain? What do they think it means versus what do we tell them that it means? Pain as punishment, pain as noble. And we negotiate and respect those values. Sometimes we can say to a patient, how much pain is necessary for redemption? Does it have to be a level 10? What about a level 8? Because if we got your pain down to a level 8, maybe you could sit with your granddaughter and read a book. These are other aspects of patient experience, family work and financial pressures. We know that sometimes patients, and many patients, if they're not working, they don't have an income. If we manage their pain, they can work. They can keep a roof over their heads. They can keep their financial insurance. Talked about a numeracy and language difference. And we're talking now also, this whole conversation is about the stigma attached to opioids, worse stigma attached to opioids. Litigation's a really interesting one. We had patients we took care of whose lawyers would essentially tell them, don't get better. If you get better, you will lose your compensation claim. You can get better after your compensation is approved. So we are poor patients and families, and we live in really complicated systems. Keith Walu has written a book called Pain, A Political History. For those of you who are really interested in this topic, I would suggest you read it because it ties to politics, it ties to compensation, it ties to spiritual values. So there are professional and ethical mandates that lead to practices that we can structure and to build safety. We have to structure and build safety so we feel safe and so patients and families feel safe. So sometimes policies allow us to feel safe, but there are some policies that don't relate to safety, but actually they relate to mistrust, and I'm going to talk about them. Assessment is an assessment of good, as an extension of good medical practice. So when we're talking with somebody about pain, we want to know their pain history, their drug history, their trauma history. Just a physical exam like anything else. And what are the previous interventions? Have they worked or have they not been working? Integrative, pharmacologic, there are many, many interventions that help pain. Pain is not just about opioids. We know that. Yet access to these interventions is not always equal. They are not always accessible to people. These are assessment documents and screening documents for substance use. If they become a routine part of our care, we're doing it 100% universal. We need to be doing it universal, because whether it's alcohol, whether it's marijuana, all kinds of stuff out there now that people are using to medicate their moods, to medicate their bodies. And we need to know who those people are and what it is they're depending on. Sometimes we do a trial of opioids, and what are we looking for? A shared review of outcomes. We want people to be better. We don't keep doing something over and over again that doesn't make people better. And so it's a shared review of outcomes. Function, pain relief. Is pain relief enough? We used to talk about this a lot when I worked at Beth Israel. Is pain relief enough, or do we also have to expect improved function in order to continue to prescribe this way? It's an ethical question. Maybe it's a moral question too. Maybe it's a question that Keith Walu answers in his book, Pain, A Political History. And we need to be doing ongoing evidence-based risk assessment, and we continue therapy if it relates to benefit. If it doesn't relate to benefit, then we readjust, we reorganize, and we educate people about withdrawal. We educate them about how they're going to harm themselves if they don't use medications the way we've asked them to use medications. Interventions are some are evidence-based. They're intended to support appropriate use. For many, they imply mistrust and they threaten confidentiality. I'm always impressed that the prescription monitoring programs, we're really crazy about HIPAA violations, and yet we allow all kinds of information about patients and prescribers to go into a central database that we have no control over how it's used. So how do we structure for safety? All the time, and especially when we're worried when somebody has a history of substance use disorder, or we're worried about how they may use medications in a way that's going to create potential harm. Team approach, family involvement, depending on whether the patient will allow that. We sometimes do frequent visits, honest, open communication. We want to talk about trust. We want to talk about mistrust. Diaries and journals. If some people do treatment agreements, this is where the policy issue comes together. Some people call them treatment agreements. Some people call them contracts. They are not contracts. Contracts are legal documents. Some people call them patient-provider agreements, PPAs. There's a website called Practical Pain Management. It's got a lot of really helpful stuff on it. These agreements are really informed consent processes. That's what they need to be. Informed consent processes. Urine toxicology is really interesting. I read an article where folks are saying to do a urine toxicology, you need to have a medical reason. You just don't do universal urine toxicologies. First of all, it costs a lot of money, and so on and so forth. So it makes sense, I think, that when you order a urine tox, there ought to be some kind of reason why you want a urine toxicology. Pill counts, prescription monitoring programs Dr. Smith talked about, referrals, and we need to mediate access barriers. The data that Dr. Smith talked about that Mount Sinai did was done by Russ Portnoy decades ago, I think in the 1990s, and found the same thing. found the same thing. So things haven't changed a whole lot. And what of those who fear our intentions in our medications, like Ruby? So there are some people who we worry about giving the medication. There are other folks who we need to talk about what it is that you're afraid of, so that perhaps you can use these medications in a helpful way that improves your quality of life. So psychoeducation, if patients are in recovery, we need to integrate their sponsors, their counselors. We can't isolate this, because this is part of their medical well-being. This is part of their medical care to treat substance use disorder. Anticipatory guidance, and I want to talk about this now. We used to talk about use despite harm. Use despite harm is one of the 4 cardinal things that we would look at to assess risk in patients who were prescribed opioids. Use despite harm, we need to teach our patients and families that use despite harm also means that if you have a prescribing doctor who prescribing for you to manage your pain, and that doctor says to you, I don't want you smoking marijuana any longer. I don't want you using cocaine. This is the contract. This is the treatment agreement. You do this, and I will prescribe and help you to manage your pain with these medications. If the patient continues that behavior, that's very worrisome, because it is use despite harm, and the harm relates to the relationship with the prescribing physician. That's the harm. Even if their lives are fine, if they only do cocaine on the weekends and their lives are fine, if they are threatening a relationship with a provider, that looks like use despite harm. We need to worry about that. Sometimes we can refrain for people who are afraid of our intentions and our medications, because addiction generally harms, and appropriate medication improves life. When we're doing it right and medicating appropriately, people's lives get better. And we structure for safety, and we let people know how we're doing that, and we negotiate, and sometimes we do a trial for medication. An invitation and the end of Ruby's narrative. This is so exciting. I got it all in. I don't know if people allowed me a little bit more time because of my technological disability, call it a disability. But I did want to tell you what happened with Ruby. So Ruby, we were able to, because we had worked with Ruby for a long time, she had some level of trust in the people who were standing over her in white coats. She had some level of trust. And what we said to Ruby was, we appreciate that your friend is observing behaviors in a hospital. We're not sure that that's what's killing the patient, but what we know about you, Ruby, and your relationship to this medication is that you have been on it for many, many, many weeks. And we have been prescribing it, and we have not killed you. We have not killed you. And that's reality testing. And when you have relationships over time with patients, that's why journals are also helpful. When you have relationships with patients over time, you can attach to that history, shared history, in a way that builds trust. And so we said, Ruby, it's up to you. We can increase the medication by a little bit, see how you do. And you are always in charge. If you want us to decrease the medication, we will do that. We will do that. But will you work with us and allow us to increase the medication a little bit so that you can be there in a different way for your son? The other thing that Ruby was very worried about is that we would take her consciousness with our medications, to make her confused, because she still had work to do with her son. She had work to do with her son. So this is a wonderful, it was an important and amazing learning experience for me. And while it was years and years ago, I have no doubt at all that there are folks in our hospitals who believe that we are using medications to kill patients. And we need to be conscious of how we talk about our work, how we talk about our medications, how we talk to home health aides, to the people that wash, that provide intimate care for patients. We need to engage them in the process of our thinking, so they're not left to our wonderings. And on that note, I think that's a sunset in Nepal. And these are all the references that I have provided for you because there's some amazing reading out there, and the videos are quite profound. There is one that is very recent, a Dr. Moore, who's an African-American physician who died of COVID. And she videoed something on her iPhone about the care that she received in a hospital and the discrediting of her pain experience as a physician. It's quite powerful to listen to. And on that note, I think, I'm not sure if I'm out of time. Am I out of time, folks? No, I have 10 minutes.
Hi, Terry. Can you hear us?
Somebody's going to talk to me. Is that true?
Can you hear us, Terry?
Well, maybe not.
Bill, would you mind calling her again?
Yes, I will do so.
Perfect.
Brad? Hello?
Oh, Terry, it's Bill.
Yeah. Yeah. What do you want me to do? Yeah.
Well, are you able to see your Q&A?
Q&A. Yes, I am.
There is a question in there for you.
Yeah. Can you talk a little bit about, okay, yeah, and then what do I do? Just sit
Just
around
keep
here?
talking, and then I'll call you with another question.
Thanks a lot. Bye-bye. Bye. Okay, there's a question in Q&A for me, and this is, Terry, can you talk a little bit about the benefits that social workers especially can play in the role of evidence-based non-pharmacologic supportive interventions for pain management, and the role in supporting the provider and your thoughts on how this could narrow the gaps of disparity, as well as, okay, this is something that is often untapped, is when the skill set and licensure. Okay, so is often untapped and is within the skill set and licensure of clinical social work, not used in interdisciplinary pain management. This is a wonderful question. You would like to answer this question live. This is a wonderful question. So social workers are trained to see people, to accept a patient's report of their experience. That is very important. That is about not delegitimizing a patient's report of their experience. Where we get in trouble, and this is my evolution as a social worker who learned about pain. I used to be very inclined to advocate for pain management in patients who I knew little about. My knee-jerk reaction was as an advocate for the patient, not realizing the complexity of pain and the complexity about how people use medications. Some people use them for sleep. Opioids are not intended for sleep. So I was an advocate. I was a non-expert advocate. It took me a really long time to develop an expertise where I could step back and, instead of my knee-jerk reaction being to advocate for patients, but rather to ask for data. What are you seeing so I can join with you? So we see people in their environment, certainly social determinants of health, understanding the community that patients are going back to and making sure that they do not go back to a place where they are not able to get their medications. Many social workers are trained in cognitive behavioral techniques, relaxation, imagery. I love the use of journals in pain and symptom management. You capture amazing information because patients don't always understand the significance of what they are giving you. Social workers who are trained in relaxation can sit with a patient and do a focused breathing exercise, just the way we did the breathing exercise at the beginning of this gig. Can do a focused breathing exercise, which says, as your pain decreases, imagine, and use imagery to help them move themselves mentally, spiritually, emotionally, out of their body into another place that is more comforting. We can teach families how to use these techniques with patients. It ought to be, if we believe that pain management is not just about opioids, then what we need to do as teams is to sit down and create a multidimensional plan. And one of those aspects of the plan may very well be opioids. Another aspect of the plan may be a pain diary to see how the opioids impact function, to see how they impact the emotional life of the patient. Another aspect may be teaching relaxation techniques. Another thing may be, for example, in a flare of pain, breakthrough pain. So somebody's walking along and all of a sudden, and we know this happens with patients who have cancer, and other diagnoses as well. All of a sudden, they have a flare of pain that comes and goes in like 30 seconds or a minute. And they say to themselves, this pain is going to kill me. Well, clearly it isn't going to kill them because they haven't died from that pain. We can teach people to talk to themselves differently. That's a cognitive intervention. A cognitive intervention. So they take deep breaths and they say, this pain has come. I know this pain. I've had it before. I know that it comes and goes. That's a very different message. We can teach that. We can teach that's cognitive behavioral interventions, relaxation. And sometimes we can actually also get people hooked up with things like massage, acupuncture, once again, depending on their resources, The other thing I would like to say is when you work together like that, it is never so, I do not believe, that the risk on prescribers, I think that risk is always there and it is different. But when you have a shared treatment plan and you document the shared treatment plan, there is something about the moral distress that maybe is a little less, because you know that you have talked with other experts or people who are becoming experts, you have talked with them and you have a plan that everybody thinks is reasonable and has some semblance a possibility being successful for the patient and for the family. And all that needs to be documented. All of it needs to be documented. On thoughts on how this could narrow the gaps in disparity. Just 1 second. Yes, Bill. It narrows the gaps in disparity. It may narrow the gaps in disparity because we're asking each other to be accountable. So by asking each other to be accountable, what we're saying is, tell me what you're seeing. And with a little bit of luck, maybe we can get to bias that way. Maybe when you have a team that is trustworthy, that trusts each other, that is a team of psychological safety, you can get to each other's biases and discover and get beneath them. So the plan that you make has less to do with bias and more to do with what everybody is seeing with a patient and with a family. The phone just went off, but now it's stopped. Let's see. Is there any other thing down here? Oops, here's another. Hello.
Hello, Terry.
Yes.
What are some ways of engaging colleagues in the work of mitigating disparities? Okay, so I'm going to hang up on you, Bill, and I can, no, how do I do it? Do I talk to you? No, just hang up.
Okay, and talk. Okay, bye. I think one of the, so the question is, what are ways of engaging others in mitigating disparities? I think a couple of things. One is that I think one of the really important things is to get very honest about the data. And to help people to understand what the data says and what it has said historically. I think this is one thing that I has been very difficult for me at times, is to give other people the benefit of the doubt, is to appeal to folks on the level of shared humanity and on the level of everybody wanting to do the best care and asking together, how can we accomplish that? How can we accomplish that? I think I've heard Dr. Smith say in another meeting, it was an ECHO meeting, I heard her say that when we're prescribing, and she maybe can talk to this on the panel, when we're prescribing or behaving in a way that is not our usual behavior, how do we understand that? How do we look at that? That is a point at which we need to be looking and talking together about what that behavior means. Who are the patients that get discharged from clinic? How do we look at data in our organizations that somehow have become reflective of bias, of fear, of whatever it is that influences that and that increases, and then it continues to support and to increase the inequities that we see. I think shared learning is really important. That's why I love the videos. John Oliver uses fuck a lot. And I'm not sure why he needs to do that, but his video on bias in medicine is very profound. So I think shared learning is very important. But I also think you need to figure out who in your system is committed to this and build alliances. Social workers used to do a lot of work on community organization, and community organization involves looking at who are your allies, who are the folks that we need to connect with. How do we broaden this discussion to community, to people in the community? Because sometimes that is the way that we're going to get over the mistrust in the community. That is the way we are going to be able to build trust and trustworthy systems. So I think in part it depends on your system, who is in your system, where your strengths are, where your supports are, and then you create a plan. And you create a plan with the idea that you might not succeed, or you might succeed in a much smaller way than you thought you were going to succeed. But the problem is silence is no longer an option. That's not the problem, that's the reality. Silence is no longer an option. So how do we work around people who are unchangeable? Sometimes we work around people who are unchangeable by building systems around them that mitigate and minimize their power and their influence. So it's a hard question, but it also is a question that requires that you look at the system that you're working in, you find out where your supports are, you find out what the real commitment is in the institution, and where that commitment rests, and then you build from there. I think that's all I have to say about that. It's me.
Hello, it's me.
Yes, hi.
Just one more comment in the chat. You've got another 3 minutes or so if you'd like to try and
I can't believe I did that talk so fast. Anyway, all right, let's see. Okay, I'm going to look in the chat. All right, thank you. Bye. Let's see. Are the same disparities about open deprescribing happening at end of life hospice versus cancer treatment? Answer live. Are the same disparities, this is the question, are the same disparities about opioid prescribing and deprescribing happening at end of life, hospice versus during cancer treatment? I would suggest that, I believe that it depends on the hospice. I would not assume. I know that hospices have a little bit more leeway. I don't know how those laws are written about prescribing, but what's very interesting is that we need to be paying the same attention. It doesn't matter what setting you're in, whether somebody's at end of life or in hospice care, we need to be paying the same attention because some of what's happening in our world is doing harm to people. And we need to be paying the same attention about mistrust, about worries. And so I don't know if the disparities about prescribing and deprescribing are happening are different in hospice or end of life. There's probably data on that. My worry is that we think that's just, that we have to worry that people who are coming to the end of their lives might not be any less at risk of somebody taking their medication or using medication in a way that that is not how it is intended. How we think about that use of medication at end of life might be different than how we think about it during cancer treatment. So I hope that's a little bit of an answer. And I really do think it depends on the hospice, how they're handling issues related to prescribing and deprescribing. Some hospices I know were delivering medication every 3 days, building structures around patients and families to keep them safe. Once again, in the interest of non-abandonment and in the interest of what we do for a living, which is to provide competent and compassionate care. This is a comment. We often use biased language when we are addressing or prescribing an issue. Yes, so this is about biased language when we are addressing or describing an issue. We need to, Ann Kellerman and I do a whole talk on language. So what you saw was just a sampling of that. The media also has an amazing influence on this, and we need to pay attention to it. And sometimes it means you write a letter to the editor. Terry, when you keep saying it's a great idea to keep a journal, is that specifically for pain or just in general? the journals that I worked with were all related to pain and symptom management. But I will tell you, journaling and diarying can be a very therapeutic intervention. And just one second. Hello? Oh, shall I finish this question? Okay, I'm finishing this question. So diarying and journaling can be a very, very important intervention for whether it's for therapeutic purposes and you're in a therapeutic relationship with a patient who has no symptoms, but it is especially useful for pain and symptoms. And there are many models on the web. I would suggest that the models that are best include symptom, the rating of the symptom, what did you do about it, what was your emotion related to it, and what was your thoughtfulness related to it.